Hello friends, I am Dr. Sourabh Patwardhan from Nandadeep Eye Hospital PG Teaching Institute and PhacoTips Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. Toric IOL and patient has astigmatism of around I think 0.75 and the toric which was selected as per the Barrett 2K formula, Barrett TK formula is around 20.5, I think 1.5 cylinder, and I'm going to first demonstrate how I use the iToric Android app. It's developed by me, and instead of the usual slit lamp marking or bubble marking, we can use this app very easily in your OT just before the surgery to get the accurate reading. I also have Callisto markerless system, so we'll also see how much error this has against Callisto, which is more accurate because you don't require to mark the eye in case of Callisto. Okay. So we already cleaned the patient. We are just waiting for the contact time to be over, and then we'll mark with the iToric Android app. So for toric IOLs, I think nowadays it has become quite simple in terms of IOL calculation because of the Barrett toric calculator formula. I think it's quite accurate and it's very easy, as well as it's available online as well, free of charge. So irrespective of whether you have the optical biometer or a device which has inbuilt Barrett, even if you have immersion A scan, you can calculate the IL power by Barrett formula online. Okay, so we'll just start with the marking. I will just show how it is marked. एक जण या इकडे, एक जण थांबा. ओके, उठून बसा मावशी. पेन दे मला नवीन मार्किंग पेन. Okay, am I visible there?
Yes, sir.
Yeah. So I'm just going to ask the patient to look straight ahead and then mark free hand with the marker pen. मावशी सरळ असं उभं राहा, बसा नुसतं. हां, लांब बघायचं. हां, माझ्याकडे बघा सरळ. मोठा उघडा डोळा. या, मोठा उघडा ठेवा. Okay, so this is the first mark which goes in. सरळ बघा मावशी. And second mark. So it's a free hand mark. Now what I do is important, so just go back a little, the camera. So I am going to use this iToric Patwardhan app, which opens up. We have to ask the patient to look straight. मावशी थांबा असंच. हां, सरळ बघा फक्त. So both eyes should be at the same level. You can check it on the app itself that both are in the same line. And then you magnify. You can use the flash also, and then you just click a image. So the image has been clicked. Now what I will do, I will center it. Okay. Put these dots on the marks. Okay, right here. Right here. So now it is over the marks. Okay. Now I will enter the axis of placement, which is 168, I think. Okay, you can see here that there is hardly any rotation, even if I marked by manual or the just free hand. The axis to be used is 168. So I will enter that, and it gives me that new axis of placement should be 169. Okay, so the error is just 1 degree, which is also corrected by this app. We also have Callisto, so bring the patient to the table. So I don't need any slit lamp marking or anything. Just before the surgery, I can do it or my assistant can do it very easily. We can even save these images. So even if we want to see it again later, whether there was any error or something, we can see it again. So by the time the assistant is preparing the patient, let's see about the microscope also. I think I have done one video on microscope also, like how you have to set up your microscope, including the IPD. So many of surgeons, when they start, they say that they get headache while operating. It may be because of convergence efficiency also, but it can be also because of IPD settings. So everyone should know what is their IPD, and sometimes some microscopes have an error. So on the marks, it might be showing say 62, but actually it is set at 64 because of the play which is there. So first, if you want to check what is the best IPD for you to operate, first increase the IPD of the microscope to maximum, and then start reducing it slowly till you get a single bright image. That's the perfect IPD at which you should operate. And also check if there are any errors which are added in the eyepieces, because if you are operating in a place where multiple surgeons are there, sometimes, or even during cleaning, it kind of changes. Okay, can you call Dr. Deepak? Give him a mic also. Can you just show the camera on the Callisto also? There you can see that we have registered. We can show the registration part again. Just register as an executor. So now you can see the eye is getting registered there. Start registering. Dab. Dab key. Yeah, now it has registered. You can see it has picked up the limbal vessel. And now go to the axis, show the axis. So this is the axis according to the Callisto. We'll see according to iToric what is the axis like. You have put 168, na? Mendes ring there, regular.
Who don't have Callisto.
Yeah, so this is the best.
Ring is a good demonstration by Dr. Sourabh.
Yeah, just now see, this is the Mendes ring. Just now see, this is the Mendes ring. It has different varieties also. You can have a non, reflecting Mendes ring, but you can see, I have kept it at 0, 180, and I will mark 169. Okay. Yeah, so this is there 180. I am marking the 169. Okay, is that clear?
Yeah.
Okay. And you can see it is almost close to the Callisto. Yeah?
Yeah, right.
Just maybe 2 or 3 degrees difference. You can see that in the hall. Dr. Lahoti?
Yes, sir.
Yeah. You can see? So even if you don't have these gadgets, you can easily mark simply with iToric. Not even slit lamp, nothing is required. And you can get almost perfect axis. Okay, so I will start with the surgery. Light off, please. So I generally switch off the OT lights because it gives me better, visibility inside the eye. This is a 2.4 blade which I am using. So I generally do a limbal, or I would say clear corneal incision, and you can see 2.4 is very nice because it's very small incision. Viscose. This is a methyl cellulose. CCC marker de dara. CCC marker, please. I will just show you manual way of marking the rexis also, because though Callisto also gives that, you can simply mark it, just center it around. This is too big. Dusra ka? Yeah. So you can see it's centered around the Purkinje image, and just press on it, and you will get an impression which can be seen. Okay. I usually stabilize the eye using the Sinski in the left hand. And we'll start with the rexis. So this is a cystitome made up of regular 26 gauge needle. Yeah, so I am trying to follow that impression which is there. Is it visible, that impression?
Yeah, it's visible, sir.
So Dr. Sourabh has not used trypan blue here because the red glow is extremely good. This is a grade 2 nuclear cataract. He is using the red glow to get a good 5 millimeter rexis. Rexis is completed now.
Now watch the hydrodissection wave. Yeah, you can see that wave. And then always decompress. And then you can rotate. Okay. शुभम इकडे माझा मास्क जरा खाली घे रे. खालीच घेऊन टाक, स्टिकिंग काढून टाक. So this is a common problem when we operate, that we get fogging. So we generally put a tape around nose, but in this case I think maybe the humidity is slightly higher. Can you move this handrest बाजू, काढ आणि बाजूला कर. Yeah, correct.
When you are using Rexis marker, is there any risk of causing epithelial damage, sir?
Yeah, it can if you rub it on the epithelium, but if you press down, then it will not cause. And this mark is very temporary. Okay, so yeah, you can talk about the incision. I think we have used 2.4. This is the anterior epinucleus which is out. Okay. And how much IOP are we using? Yeah? Okay, so I will try to chop. It's a soft grade. There goes the Sinsky in front and it's chopped. So it's just choppable. If it was even softer than that, I might have preferred a train divide technique. So the first piece, this one I want to take it out. So I have divided it to 4 pieces only because it's a soft cataract. So you can see I have kept my bevel sideways. Just let me know about focusing, because is it focused? Yeah.
Yeah,
Okay.
it's focused well.
So just keep it sideways, and it's because it is soft, hardly any energy is required. Most of it is being taken by the aspiration only. You can see that. And the plane here which I have kept is iris. It's not at the CCC, but you can see that it's at the iris plane. Okay. Now we'll go to the cortex aspiration. Next patient is ready. No? Okay. हाँ, yeah. First steps चालू कर सकते हैं. So once I put the IOL, you can go back in there. So now the next is the cortex aspiration. What are the settings?
500 vacuum linear, 45 flow rate fixed.
Yeah, you can see it on the screen as well, I think. So I will like to just zoom it and show you the steps I have shown. Hold, just see I am pulling it posteriorly, and not just centrally but posteriorly, and how it comes off very quickly. Okay, in 3D you can visualize that. See. Yeah, so you don't have to even move it around if you're pulling it posteriorly, because it's the fluid which cleaves. I think Dr. Vasavda sir has shown this technique with bimanual. It's called POPs or something. Maybe someone from the audience can. POPs only, yeah. So what is done is that you pull the cortex back. So fluid kind of goes in and cleaves the cortex away from the. And now here I am going to use 1% hyaluronate from Care Group, and this is my favorite nowadays. Reason I will tell you why. So now the small this thing fibers you can just do hydro polish. Can you see that hydro polish? Jet of fluid, yes.
Yeah.
But
Trying to remove
yeah,
the epithelial fibers.
whenever you are using any cannula, you have to hold the hub. That is very important. Otherwise, you may have flying cannulas, and that is not good around the eye. Of course, lure lock is the best. So I think that's what Alcon has modified in the newer Centurion and Legion, that they have the irrigation line has a lure lock. So sometimes during phaco, the irrigation just comes off, which is risky. If you have lure lock, it is definitely much better. Okay, so this is a acryol toric IOL. And this usually goes through 2.4. So this is the 2.4 incision which I have made. Goes in. Go very slow. One principle which I think somebody told me about IOL injection is that the direction of IOL should always towards the equator of the bag. I think that's a good, principle to follow. Many times we inject it towards the posterior capsule unknowingly, and that may cause tear in the posterior capsule.
So
Okay, now
it should travel parallelly.
yes, microcapsular axis scissors पण एक micro scissors. Now just watch the 1% hyaluronate, and that will tell you why I prefer it. Yeah, just comes off quickly.
In one single mass,
Yeah.
it just.
And the advantage is that if there is no visco left at the end of the surgery, patients are very comfortable. Even in the late post-op, these patients I have found, they have no complaints at all. Otherwise, few of them will have continuous irritation, etc., etc. Okay, now we'll see the axis. Yes. So you can rotate the IOL either using the Sinski or using the probe itself. Yeah. So now you can see the axis. Of course, I can use the manual marks as well, and here it is almost close together. Okay. Rexis is slightly on smaller side. I thought it's quite small, but it's I think fine. It's around 5 mm or so, and covering the optic, so that is fine. Can you see the this thing marks on the corner?
Yeah, it is
those
visible.
are the callisto.
Yeah.
And these tiny marks which are there, these are the marked by the iToric. So hardly any difference. This is the mark by iToric. I am just showing it by this cannula.
Yeah.
And this is the callisto. Hardly any difference. Quite accurate. Can you show the CCC of callisto? CCC mark of callisto. CCC. Make it 5.8, please. Make it. It's not bright enough. I will just. See, you can see the CCC mark. So it's definitely more accurate. You can see the 5.8 is actually the size of the optic. Okay, so it's exactly showing what's the size of the optic. So you can use that guide also for accurate CCC sizing, also centration. Well, some cases we can center it around visual axis, like high angle alpha is there.
Yeah.
We can. Okay. Now show the toric marks. Okay, it looks perfect.
Yeah.
Any suggestions to change or anything? Okay, so that's the end of the surgery. I will just push little bit of Vigomox. Yeah, that's little bit of Vigomox. I will ask the patient if can see the light or not. Maushi, light disto some more. We ask that because if we pressurize the chamber too much, the PL goes off, and that should not happen.
Dr. Sourabh, do you take any precaution to see that there is no post-op rotation?
Yeah, so generally in my experience, we see the patient after 1 week directly. We don't see next post-op day. And even if there is significant rotation, which means that the residual cylinder is say more than 0.75, we can consider re-rotation.
Okay.
But in my experience, if the patients are quite comfortable with post-operative vision, I don't generally, advise a second intervention. Yeah.
Does patching for 2-3 hours in the immediate post-op help in the
Yeah,
prevention
I
of
have not
rotation?
tried because even with patching, the eye will move inside because the other eye is open. So then we have to patch both the
Both
eyes
the
to
eyes,
stop the
yeah.
eye movement. So maybe if we ask the patient to avoid any jerky movements,
Jerky
they go
movements,
back with
squeezing the
in
eye.
bus or something like that, might cause this thing. But I think it's primarily to do with the IOL material and the design.
Yeah, how
Because
tacky and sticky is the IOL
yeah, I think
material?
that is the most
Most
important
important.
part about this thing. Because these IOLs are quite big. I mean, if you see the haptic to haptic, it's almost 12.5,
Yeah.
and the bag is just 9 millimeter. So it's already stretching, trying to stay in the place.